I think coffee break is very seducing up there, but we need to start because we need to keep time. And what a pleasure to introduce my boss and dearest friend, Professor Azzal Bak. She was the head of the unit of child psychiatry, and the head of the whole department, and she we ignore that.
It looks like they still need you because you're here.
Yeah. What she said does not register. So, and she's working even more than when she was head of department. We have this chance to tell her, come, we need you. And she's going to present the impact of technology on youth mental health.
Shukran, Saad. I'm very pleased that I have two very old friends as chairpersons, so I feel comfortable. Sana and Saad. I know time is tight. The topic is, I found a huge thing to talk about, so I try to give snapshots and then we can discuss any time about different points of view. I think technology has affected our work, and the advance in technology has shaped and is shaping advances in psychiatry and less so for child and adolescent psychiatry. Because there has been tremendous advance in medicine in general, in the use of technology. To me, psychiatric disorders are lagging far behind. And adolescents and young people are going far more fast than we can just run after them. I'll be talking about positives and negative things related to the impact of technology on youth mental health, what we see in our practice. So I just was wondering, has technology rewired our brain and or their brain? Is there a different set of mind? Are the young generation thinking differently? The physiology is different. The neuroplasticity is and will soon be affected because of the impact of the technology on their brains and how they are handling it. And if so, are we still to be talking about negative aspects of the internet on the adolescents, or we have to stop and start to use positively the wealth? Will this offer us a wealth in our job through which adolescents would benefit of it and it helps us in our job? Of course, all of you know that there are going great debates about what is good, what is bad. Experts are with using technology. Others, they are always worried about the bad effect of the internet on the young generation. But if accepted or not, technology applications are there with children, and they like it, and they are using it. And the debate which is going recently is about the impact of the screens on their lives and how it is developing their developing brains and how we are going to handle this. But at the same time, when you ask them, they welcome and they are happy to be using new technologies to use the network in their care and in diagnosis and in getting the information. But parents are having a very hard time following them. And we as professionals, I think we are having a hard time too. But after all, it is unwise to ignore all this potential of this digital world on youth development and health. There is no detour. We accepted screens, so we have to deal with it. Because internet has been embroiled in their lives. They are enmeshed with the internet all through. It is our problem, not theirs, I think. So I started on asking some questions. Are there positive or negative impacts of technology on young generation? Could this help for the promotion of mental health and more in the treatment of psychiatric disorders to some extent. In 2017, UNICEF delivered a report saying that a little bit of internet is okay, but not using at all or overusing is not good for the mental well-being of young children. And the Pew Research Center made us know that teens are accessible over the internet most of the time. They use it everywhere, in home, in the bedroom, and they're not only using mobiles, they are their smartphones and the cell phones in more than 95% or amounting to 95% of youth using them with all the platforms that we all know about, YouTube, Instagram, Snapchat. Adolescents themselves in a research, this World Internet Project, they found out that 50% of them said that they are online almost constantly. It's a very long time, sometimes maybe more. So in Egypt, we have the same issues, we have the same problem as well. And this same project found similar results in Egypt concerning the youth with all the platforms, the Facebook being the most popular and is still the most popular that they use. So we have right and wrong, good or bad. Then we come to the word concerns about the effect of digital technologies on psychiatric problems, that they might lead to perpetuate, be the cause of some psychiatric disorders. The most popular of these are these lists. I didn't go for the whole list, but because we will see the chart with the positives and negatives, we are worried because things might go wrong. I'll just show you some significant pictures about children sitting in front of the internet or the laptop, the mobile phones, and we see this frequently. We see children as young as 3, 2 years playing with the mobile phone, playing games. We see this frequently. They all are sitting beside each other, but they are not relating to each other. And the worst is this. The family, everyone is sitting over his mobile. They are not communicating with each other. So we know the benefits, the risks, the assessments, and this has been handled many times about the positive effect and the negative effect. So mostly the internet has been attacked as a negative tool because they cause a long list of problems for kids and problems with the family and problems with communication. So it is always accused as being negative and as if the brains of the young people are becoming like this. What I don't like more is the effect of the smartphones by parents. We are seeing frequently parents who are distracted and they are attuned towards their children. They are not responsive. They are not communicating with them. The phone is creeping into the emotional quality of their interaction, leading to negative consequences, not only on the kids, but on the parents themselves. It affects their bonding and their parenting. And kids as young as this, see, she's attuned, she's just walking, having a walk with the child, but she's always concerned about her mobile. Because, as we all know as child psychiatrists, that kids need human interaction. So the problem of the technology and the human interaction here would always be a worry in the back of our minds. We have to admit there are positive aspects even ongoing, not for the future, but there has been good positive aspects of the use of technology or internet with the young generation. There are cognitive, emotional, and social positive aspects. It has proved a lot of benefits in learning. It helps in education, in psychoeducation. The websites and blogs all we go through and they go through to get information. They have opportunities for support groups, which is positive effects of the use of internet. Psychotherapeutic interventions with its pros and cons. And it can help a lot through mental health promotion, prevention, and giving proper information rather than the misconceptions that they can get over the internet by their own search. So, and technology could be a good help for enhancing training and practice for them and for us. It proved efficient and effective, especially in kids with learning disabilities, those with sensory problems, auditory and visual sensory deficits, and those who needed assistive technology. So there is a lot of benefits, positive aspects of the internet then that was applied and we can apply. So I will ask the question once again. So is this positive or negative? Does it have a positive or a negative impact? I think, to me, this looks like this new seesaw, not this old one, of course. And it's a matter of balance. When you're always off balance, then things go wrong. If you're maintaining the balance, it's okay. Okay. Can we make use of technology for promotion and treatment of mental health problems and disorders? There are several trials already going. But before that, we have a problem with the young people that usually they are reluctant to seek our professional help. They don't like coming to the psychiatrist. And usually, the start of the disorder, there is a delay, as Professor Akasha was saying, between the onset of the problem and them or their parents bringing them for consultation. But they do seek through the social networking. So why not make use of this? And it might be, it is a positive opportunity, promising to use this social networking to deliver organized, youth-focused online mental health interventions. There are many benefits already, because in Egypt, مثلا, we have areas where there are no accessibility for child psychiatry. They have to travel for a very long distance to come for consultation or go into an institute for treatment. So why not the service when they can make use of this kind of e-mental health and benefit from them. We have a population of around or more 50 million young people. And we have a number of psychiatrists registered, those registered in the ICAPA of child and adolescent psychiatry, not exceeding 100 until now. So imagine the discrepancy between what we have and what we need. So maybe it's a good idea sooner or later to think about how to do the job through the internet. There are a lot of non-professionals and untrained others involved with young people. So better do it than not. And this will help in better accessibility, it will reduce the cost, we can have standardized and personalized, tailored designs to help the children, adolescents. There has been tools already used on platforms used for screening of for the presence of risk symptoms, and there are applications for risk assessment, especially for suicidal patients or those having suicidal ideations. It can be used in monitoring recovery, following up of the patient, monitoring relapse. How can we measure some measures for an outcome? So they could be used complementary with the current mental health system, and they would help us a lot. Smartphone applications are being used not in Egypt, otherwise all over the world, and there are a kind of applications that are currently used to help the documentation, the registration, identifying the triggers, reminders, those used in exercising, in the therapy-oriented apps. There might be good ideas about using them to help our young generation. The online counseling and therapy is an ongoing. I don't know how much is it structured or organized in Egypt. They appear like done individually without proper supervision, and people just do online internet-delivered cognitive behavior therapy. Psychodynamic and interpersonal psychotherapies to a much lesser extent, but online diagnosis and treatment are there. Online computer games, and there are some parent training programs, technology assisted for parents to help children in handling their problems, for example, those children having disruptive behavior. Online support groups are available, and I think one of the nice benefits of the internet is these online support groups. They help children a lot, especially in those with chronic medical illnesses, where we have problems with patients with chronic disabilities, chronic medical disorders, cancer patients. These online support groups, where they are universality and all over the world, it helps children a lot. Reviews and meta-analysis has been done. Recently I've read about New Zealand and Australia specifically. They are very much concerned about this internet, email, mental health delivery system. And this research was testing the effect of e-mental health, and they found that there is a positive good effect for computerized CBT, and the mobile messages help in alcohol consumption, game-based interventions that youth like, they help in depression, and to a lesser extent or moderate effect in applications that help treatment of depression and anxiety. That's what they found. I have to mention an important point. I think this would put us in some dilemma about, so what is the role of the child psychiatrist here? What about the doctor-patient relationship? We depend a lot in our therapeutic relation with patients about this alliance, this positive relation with children. How would this be reorganized or reformulated still to keep the touch? The second point is, I think we as psychiatrists are and were and still are slow adapters of technology, of information technology in our practice, compared even to other medical specialties. So clinicians and practitioners, I think we need to be thinking in a new skill set mindset first. To keep abreast of the technological developments, just not to say no, it's a negative tool. We need to think positively about keeping abreast with technological development, because we can professionally incorporate technology into clinical assessment and in our practice. But there are some precautions here about the guidelines, issues of malpractice, how would this affect the relation, and as written, we have this pharmacology, medicines are FDA approved, but apps on mental health they are not approved by any association, or they are not FDA approved. There are many pitfalls regarding the use of internet in treatment, the confidentiality, what about the conflict of interests, the privacy of both parties, the safety and the reporting. We have many issues here that we have to be thinking about. Okay, then to sum up. Digital technology is constantly changing and it is influencing mental health of young people. Professionals are having difficulties and dilemmas to deal with them. But it is crucial to adapt a different approach to minimize the risks without restricting the considerable benefits that we can gain of these opportunities. And it is our job, and we are responsible about families and young people to educate them about appropriate digital use and the risks they are facing and help them, giving them tools to help them in this and empower them to be responsible online. Research, and it is relation to the current practice, the industry and policy, of course, are all priorities. Because I have to sum up that old myths and old treatments and old policies we can no longer apply. They are not any longer tolerated. رضينا أم أبينا. You remember this one?
Yes, yes.
I think there is, يعني في ناس هنا ما يعرفوش ده وما يعرفوش يستعملوه. You don't know how to use this phone. Remember it. No, not backward. It goes back on its own. Okay, but now it's like this. We come from the generation who use this one. And thank you very much.
حضرتك طبعا شكرا دكتورة عزة. It was very informative presentation وفيها creativity وعزة فيها. وفعلا you admitted a very important issue, the roles and roles of the media وخصوصا في الادوليسنت الحقيقة. يعني إنجاز ده في الchildren for under guidance و they can be controlled. في الادوليسنس الريسك فيهم beyond the imagination والابيوز الحقيقة. يعني اعتقد ان محتاجين حاجة regulations بقى to control this، مش على مستوى personal level، لا ده حاجة governmental عشان الدنيا تتظبط يعني. it's very hard فعلا. طبعا كل الناس I know they want لانها tempting وكل الناس عايزة تسأل. yes we'll يعني هتذكر بس بأقل يعني. And now and now we are going to move to the next speaker.
It's a pleasure to introduce Dr. Alain Grégoire. He's the founder and chair of the Maternal Mental Health Alliance. He's a member of the NICE, National Institute of Clinical Excellence Guideline Development Group for Antenatal and Postnatal Mental Health. And he has contributed to the development of policy guidance and clinical services in the UK and abroad. He's determined to ensure that all women have access to care for their mental health, which is at least as good as the care available for physical health, in pregnancy and postnatally. Dr. Alain is a consultant perinatal psychiatrist and honorary senior lecturer at the University of Southampton. He set up and leads the national award-winning Hampshire Perinatal Mental Health Service, which provides comprehensive, integrated, community and inpatient services to women with severe mental health problems in pregnancy and postnatally. He has conducted research into perinatal services, mental health of mothers in prisons, and other aspects of perinatal mental health. He began his postgraduate medical training in obstetrics, but on finding that the most ill women who also received the worst care were those with mental health problems. He switched to psychiatry, yes, and completed his training at the Maudsley Hospital and the Institute of Psychiatry.
Thank you so much, and it's a huge pleasure to be here and speaking to you all at this important conference for you. So thank you very much for inviting me. And it will also be a huge pleasure that I'm coming back to Cairo to also speak to your obstetrician colleagues in about a month's time. I hope that this first word in my title on the slide here, uniting, will be something that I can make a small contribution to by essentially giving exactly the same messages to your obstetrician colleagues as I hope to impart to you. And that is really the theme of what I'm going to try and communicate to you, is that the take-home message is we all need to work together if we're going to get this right, because we can't achieve really great things on our own. And if you can achieve something on your own, well, then it's probably not really as great as it could be. Yes, I'm a perinatal psychiatrist. This is something that exists in England now, but does not exist in most parts of the world. We have either adult psychiatrists or child psychiatrists, sometimes old age psychiatrists, sometimes addiction psychiatrists. I come originally from a background of adult psychiatry, but my training was absolutely also in child psychiatry, and my practice, since I have been a perinatal psychiatrist, has been looking after both mothers, sometimes fathers, and their babies, and most importantly, the relationships between the two. I have the very good fortune to work in collaboration with a number of organisations internationally who have come together under the banner of the Global Alliance for Maternal Mental Health to fight one of the most important battles we need to fight for humanity at the moment, which is getting the mental well-being of mothers, fathers, families as good as it can be, because the future, we know the science, and you've heard some of it up until now already, the science tells us very clearly that our earliest years, and in fact before birth, our fetal life, will govern our lives until we die, and will even govern when we die. And this is critically important to the future of humanity, and we must invest. So these organisations are committed to that, not just in high-income countries, but if you have very little money, you have to choose very carefully how you spend it. And I hope to persuade you that even in low-income countries, and I know Egypt has moved to being a low middle-income country, that you need to be careful with your money, you need to spend it where it matters, where you get the most benefit. And this is one of those areas where you absolutely get the most benefit for the future. So we have a challenge worldwide. We have 196 countries and 131 million births. This map does not show births proportionately, but Egypt is overrepresented in terms of its population size and indeed landmass in terms of births. So you have a lot of births per head of population, so these messages are very important for Egypt and for a number of other countries. As we heard earlier on, in fact, many European countries, the birth rates are shrinking, and we are contributing less and less to the future of humanity. Maybe that's a good thing, given what we have achieved over the past few centuries. 131,000 women with this extraordinarily severe acute condition known as postpartum psychosis. And right now, as I am speaking to you, as we are all sitting comfortably in this very nice lecture theatre, 13 million women who are at the moment suffering the gruesome experience of being depressed during the most important time in their lives. And 90% of those women are in low and middle income countries. So I'm very conscious that I come from a high income country. I'm incredibly fortunate. And we have managed to persuade our government to invest in this area. And who am I to go around the world saying to anybody that they need to spend money on this when there is so little money around. But we have so many women suffering and the futures of so many families affected that this is, in my view, critically important. Does the science tell us that we are ready to start a movement for change? Well, looking at the science, I have absolutely no doubt at all that we are ready. And in fact, it is criminal negligence on behalf of governments and professionals to not act. Because what is the point in having fabulous academic institutions that do important research if no action is taken as a result? The whole thing is a complete waste of time. And it is my view that researchers have a responsibility not just to do excellent research, not just to communicate it to their academic colleagues, but to influence change, because they are best placed with the knowledge to influence that change and to make sure that something comes out of their life's work of research. So we do have the evidence of needs, we have the evidence of the economic and social consequences of needs, we do have consistent guidance across the world in high-income, low and middle-income countries, and the evidence base that goes with it, and we have models for delivery. So there is no excuse for inaction. So what about the epidemiology? Well, we know quite a lot about the epidemiology of, let's take for example, depression in the perinatal period across low and middle income countries. And that varies considerably, but a pretty consistent picture emerges, which is that the rates of, if we just take the example of depression, I'm not talking about anxiety disorders, the full range of those, psychotic illnesses, PTSD, just one diagnosis, depression, we have a rate of between 20 and 30% for low and middle income, for women in low and middle income countries in the perinatal period. Now, if you compare this to the epidemiology for the physical health conditions that severely affect the health, well-being and futures of mothers and families, you can see that this is by far, the most common serious medical complication of having a baby. And yet worldwide, in high, low and middle income countries, we invest considerably in physical health care, universally, for all women in pregnancy and postnatally, because we know this is a priority for our population. We know that if we invest in healthcare at this time, it is of value for many, many years, and indeed, the science now tells us, generations to come. But we are neglecting the most important cause of morbidity, because this is not part of universal healthcare during maternity in most countries of the world. And most women suffer in silence. And if you doubt that depression belongs with these other so-called serious conditions, I know there is blood with some of these, and emergency acute excitement with masks and green gowns and people with sharp knives. But if you doubt that this is a cause of serious problems for our human population, remember that by far, amongst women of childbearing age, depression is the most burdensome condition If you add up life years lived with disability and premature death, this is what we should be worrying about. And who are these women of childbearing potential? When is the most common time for them to develop mental health problems? In pregnancy and postnatal. That is the peak time, by far, for these conditions to develop. If you're only interested, because you're an adult psychiatrist and you like excitement, you're only interested in psychosis, let me tell you, there is no time in humans when psychosis is as common as in the immediate postpartum period. No other time in humans. And it only happens in half of humans, women, at this particular time. But not only is this the most common time, we can predict the date when this psychosis risk is going to happen. This is a gift from God. Fantastic. So quickly, let's do something about it. Let's screen all women and detect those at high risk. Do you do it systematically across your population? No. Do we do it systematically across the world? No. Has the science told us we can do this? Yes. How long have we known this? At least 20 or 30 years. If this was cardiology, this would be a national scandal in every country of the world. But because it's mental health and because it's women, we just let it go. Give the researchers some more money and let's do nothing. It's outrageous. It's outrageous. We cannot let this continue. Do we know who these women are? Well, yes, we can predict about half of them, because these are women who we already know, and if we don't, they do. You only have to ask them, have a history of bipolar disorder. If you have a history of bipolar disorder, and you stop medication, which as you heard this morning, many women do and many doctors advise women to do in pregnancy, your risk of becoming ill is 50%. During the pregnancy, and if you are lucky enough to survive the pregnancy well, 70% postnatally. There is no other situation in psychiatry where the risks of serious illness are so high and so predictable. What do we do? Very little. Yes, I must make sure I get a chance to talk to all my slides. What about suicide? So you don't care about morbidity. All that interests you is whether women die or not. Okay? Well, let me tell you that women die of their mental health conditions in pregnancy and postnatal. In high-income countries where we have invested enormously in universal physical health care, we have dropped the rates of the other causes of death. And suicide is in most high-income countries the highest, or in the top 3 highest causes of death. In low and middle income countries, the data is not as good, but looking across all the research that is available, a recent review estimated that about 1 in 20 deaths in low income countries are from suicide. This is a very high rate for a single cause of death. What is the impact on children? I've only talked about the mothers so far, and that, to me, should be enough reason to act. We have huge numbers suffering, unnecessarily, because we can do something about this, but the children as well. And sometimes we don't care about the women. Sometimes countries are not interested. But if you tell them that the future of their children will be affected, and we now have data into the mid-20s showing very clear and large effects on children in terms of risk from maternal mental health problems in pregnancy and postnatally, look at this list of effects. Surely this is enough reason to do something about it. Now I should stress, because I'm aware that statistically there will be people in this audience who have faced exactly these challenges themselves, and this is obviously always the case when I'm speaking to audiences of people interested in this topic. I should stress that this is an increase in risk, okay? It is absolutely not inevitable that children will be affected. But the risk increase is there, and there is no point pretending it is not there. So, not inevitable, but another strong message, and very important to us as professionals, not irreversible. If you do nothing, yes, the evidence is continuity at least until in the mid-20s, into adulthood. But if we act, growing evidence that action, professional care, good quality care, even non-professional care, can change the course for these children. So just looking at some of the data, and there isn't time to go through all of that list and show you all the data, you will have to take my word for it, but just looking at some of the data, here's data on growth impairment in children, meta-analysis from a large number of mother-infant pairs across a number of low and middle-income countries across the world, showing very clearly a significant effect on child growth, and in fact, in many of these studies, the most important predictor of child growth was maternal depression. And you might go, whoa, that's ridiculous. These are poor countries, there's not enough food. How can it be that maternal depression? Think about it. It's obvious. If the most important person for getting your food to you is your mother and her mind isn't functioning properly, it's not surprising that there will be poor growth. And if the development of the brain and the body in infants is utterly dependent on good interactions between the primary caregiver and the effects are not just the mother, but we know the father and other primary caregivers, then growth won't happen so effectively. We know this. We've known this for a long time. And yet sometimes we're surprised at these findings. So if you look at the risk level from the studies, the studies that have looked at this, you find an extraordinary, actually that should be down here, level of risk attributable to maternal depression. And this is a study, in fact, from the UK, so this is a high-income country study looking at the effects of anxiety and depression in pregnancy. This particular slide shows the effects of high anxiety in pregnancy. I show this because it's got pretty colours, but actually there are now lots of studies worldwide in high and low and middle income countries. I haven't got time to go through them all, showing pretty much exactly the same thing. So this is a consistent finding emerging. You double your risks of child emotional and behavioural problems, and we now have, I mentioned this is the slide for the 7-year data, but published we have the 16-year data, and in fact we now have under analysis the 24-year data. So we know there is continuity over many years with this increase in risk of child emotional and behavioural problems. And this is another slide showing a similar effect, but showing how maternal depression or anxiety, so this slide, SDQ score, so the higher the worse outcome for the children. This line, no antenatal or postnatal. This is antenatal or postnatal. This is both. So you have a cumulative effect. The longer and the worse depression or anxiety is, the greater the long-term impact on children. Obvious message there. If we systematically detect these extremely common problems and try and intervene, then we should be able to reduce those. And we are now seeing studies that are beginning to do that. Partly having examined the science that tells us the mediating factors that lead from depression and parents. I mentioned to you, I've shown you mostly maternal data because that's where most of the research is, but this applies to the involvement of fathers as well. And that seems to be the case in all cultures, even cultures where fathers historically haven't had a big role. Sensitive parenting by both mother and father is really important to the development of children through these factors, which to most of you who are working in child mental health will be fairly familiar. Just another interesting slide to show you. This is a fairly recent study that looked at the interaction between your genetic risk from parental severe mental disorders and the mediating, modulating effects of having or not having a mother with depression during the course of the pregnancy. And what you can see, the red line, is where there's both a close family history of severe mental disorder and antenatal depression in the pregnancy. So what's happening is the antenatal depression is very considerably increasing the risk that comes from the genetic first-degree relative of all of these conditions. So again, a message: yes, we can't necessarily change that first-degree relative genetic risk, but we should be able to alter the rates and the risks of developing depression antenatally, and this will have an impact on the whole of adult psychiatry. And it is the greatest opportunity we have in psychiatry for genuine prevention of condition. The best one we know of. What are we doing about it systematically? Nothing! Nothing! We're doing nothing. Why? Oh, because there's not enough work for psychiatrists, there's not enough mental illness, so let's keep it coming. Nonsense, of course it's not that. Maybe it's because we're just so busy dealing with the consequences of what we're not preventing that we haven't got time to think about preventing it. Or maybe because there's no science. Well, I'm telling you, the science is here. So action needs to follow. I'd like to just show you very quickly this video because it's the fastest illustration I can give you of the importance of two interventions happening hand in hand. Looking after the mother's mental illness optimally and rapidly, because in general adult psychiatry we have a long, rather poor history of taking a long time to help people get better. Well, in the perinatal period, you haven't got time. You've got to do it quickly. So optimal, effective, rapid treatment of the mother and the mother-infant relationship at the same time. Not waiting, getting on with the job. Okay? So this is a woman, she in fact has a severe mental illness. She's given me permission to show this for educational purposes. You can see her face in the mirror and you can see her baby. And you will see in the first half of the video a really very dysfunctional interaction. Both watch the mother's face, but you will also see this very clearly and in my view very painfully in the reaction of the baby. Second half of the video, 6 weeks later, same mother and baby, you will see a huge difference. We have treated the mother with better medication, and in fact this was a lovely example of what we heard this morning. We switched her to clozapine. Amazing difference in her parenting behaviour. She was suddenly there again. Her mind was back on track. And you will see a difference, a response in the baby. This is just 6 weeks later. So clozapine, plus we did video interactive guidance with the mother and the baby. A manualized intervention, very effective, very rapid, very easily learnt, so a rapid training course. Any profession can do it, so you can get your nurses doing it. This mother is in fact distracted by voices. She's having hallucinations. But she's trying. She's trying. This is a highly abnormal interaction. No eye contact, flat face, no response from the mother. Yeah. Baby makes a noise, but mother doesn't respond. There's something non-continuous. Okay, so this is just 6 weeks later, same mother and baby. Looks like a bad start, but this is a good start. This is a baby saying, do something! And this is a mother quickly trying something, and then trying something else. They're communicating. Baby makes a noise, 3 seconds later, mother makes a noise. 80% of interactions are led by infants from birth. Baby's inventing a game. Mother's watching, listening, learning from the baby. Try something else, baby not interested, mother instantly knows, puts it down. I want to play tissues, okay, I play tissues with you. Happy mother and baby. Completely different trajectory for that child, emotionally, behaviorally, cognitively. And risk of mental illness later in life. Completely changed. 6 weeks. Specialist care. I need to stop for a second just to mention, in all the literature that's coming out of high, middle and low-income countries, one of the most, if not the most important mediating and modulating factor in the relationship between maternal mental health problems and their epidemiology and impact on the child long-term, including intellectual, cognitive, emotional, behavioral impact, is the role of domestic violence in the home, including in pregnancy, when we now see the impact of domestic violence going on in the home on the later development of the child years and years later, including not being subject to abuse but witnessing abuse of one parent by the other, having an impact on the child. This is an unbelievably important message for our population, because domestic violence is rife. In fact, in many countries, it's the norm. And if men understand, because men are the main perpetrators, that they will affect the development of their children forever, there is no going back, there is no I want to do that again, better. I think with that message, it might be possible to change this terrible ill in our society. Even though the suffering of women is unimportant to people, the futures of their children suddenly may change attitudes. And this is absolutely the case with regard to how common mental illness is and how severe the impact is of that mental illness on the child. And it impacts on fathers as well. So just to say in very quick summary, because I can't go through all the data, this model is absolutely clearly demonstrated now across the literature that we have not only transmission via mental illness and epigenetically directly in terms of mental health problems, particularly in pregnancy and postnatally, to the next generation, but that next generation themselves become parents and will further transmit those disadvantages and those added risks to the next generation and the next generation. So you might go, oh my God, all is lost, we have no chance of escaping this terrible continuum. But of course, you are the first generation that has this scientific knowledge. This is fantastically good news that we know this. We have never had this opportunity before, but we must grasp it. And if we don't grasp it, so this is data of the high-income country, this is data from the UK, the London School of Economics has calculated that not doing nothing, but just leaving things as they are in the UK, costs us £8 billion for every year of women giving birth in the UK. £8 billion, almost as much as Brexit is costing us. And if we do everything that NICE says, the National Institute for Clinical Excellence, our guideline, evidence-based guidelines, it costs this much. Okay? You can't see that figure because it's so little money, it's ridiculous. Okay? Now we showed this to the government a few years ago and they said, okay, you can have the money. I promise you, they did, and they gave us the money. And we are now developing services because they didn't care about the morbidity in women or the futures of children or the deaths. None of that seemed to convince them. But we told them it costs money. Oh, okay, let's do something. So this can be helpful. And of course, we've known this for many years, and I'm sure you're familiar with this graph, Heck Ekman curve, so-called. He got a Nobel Prize for doing all the work that underlies this, but shows very clearly a message that you've heard several times today, which is that if we intervene early, it actually costs us less, it actually saves us money. And it saves the future of humanity. There's lots of policy. I'm going to whiz through slides now because I've gone over time. There's lots of policy and guidance to tell us what to do, so we can't pretend, oh, nobody knows, because we do know. And there's lots of evidence that shows that we can change things. So this is a lovely study that looked at the impact of secure attachment on the fetal effects. And this is with secure attachment, you see this effect of antenatal anxiety on child development just completely disappears if you can achieve a secure relationship. So it's never too late, but the earlier you get on with it, the better. And we know what to do, but we know also that there are challenges. We can meet those challenges, and the research does show that even minimally trained health workers can deliver effective interventions out in the community. But we still need to look after the women with the psychoses, but there are fortunately very few of them. It's a good place to start, though, to get the expertise. So I'll just skip through these. We've got this evidence. We know that trials are effective. We know we can deliver this with minimally trained health workers, so it can be cheap as well. We know what to do in high-income countries. We know what to do in low-income countries. The experts and the leaders have got a really important role to play in communicating, in training. As we heard earlier on, psychiatrists should be spending at least 50% of their time training other cheaper people to do the work and not spending their time doing it themselves, because there is too much need. You cannot sit in your office and work all the time. You will never meet that need. So you need to think differently. And that is really difficult. But we are at the moment in our world making things worse, not better. So we have a lot of work to do. I've recently retired from my clinical work, so I leave it up to you to get on with that task. But I am happy to carry on campaigning to help you and get for you as much support worldwide and nationally as you can. But my advice to you, in order to achieve these objectives all over the world, and I'm skipping through my slides here, is 4 words. You need to get together. Don't just speak amongst yourselves. Speak to everybody who cares about this. Agree together what you want to achieve in your nation and for your population. Develop the expertise and the models of care, which you can do here and starting now, and demand change. Never let anybody tell you there is no money. There is enough money for a beautiful palace. There is enough money for some traffic lights. There should be enough money for the future of our children. And remember what Nelson Mandela said. Thank you very much.
You started your talk of effect on relationship. I guess there's a wider cost, because it does affect couple relationship. We see sometimes families where father has left home because sort of undetected put in a depression. The children, and they've chosen another partner. The youngest, the older siblings get affected. So there's a wider cost to this. But